Dyssynchrony Bootcamp. Nice. Thanks everyone for showing up. Weekday. So, no expectation if it's sort of too intimidating, especially if, you're not sort of used to maybe like looking at them systematically and then figuring out like what's going on and what to do about it. And obviously, I'm just looking for like your thoughts on it. It doesn't need to be right, not even close. And each level is going to be different. So, and we have like a mix of people here, honestly, between our nurses, physicians, APPs, RTs, etc. So, what the expectation, I think, for everyone, the baseline is just, there's something wrong and we need to do something about it. So, depending on your level, if that's, I think empowering like nurses to, recognize something's off, I think a good landing spot for, let's say, a bedside nurse in the ICU would be, something's off. We brought it up to a provider. If they say, all right, go up on the probe or make the Presidex, 1.2 or something, this hopefully would arm you with the knowledge that like, hey, we're already, at our RASS goal of whatever it is. And I don't think the patient needs more sedation. Do you think there's something we can do with the ventilator? Then obviously we need to be very careful about how we bring up the next point to the provider, because the last thing you can do is tell a doctor what to do, because they do not like being told what to do. And we already know that. All right. So dysynchrony. And I sent out that sort of like like boot camp questionnaire just to get a sense. And honestly, I thought this was really telling, just like what a lot of you guys sent in. The universal theme seems to be like everyone is like uncomfortable with reading waveforms, which is across the board, from physicians to RTs. And I can only sort of speak from physician standpoint, obviously, but docs aren't comfortable with this stuff, like not even close. And it's unfortunate because we're not taught it very systematically in fellowship. And then we're kind of like expected to be experts on it when we get done fellowship. And there's like no vent boards that you do. And now you're like all of a sudden a ventilator expert. And they asked some questions on boards for my newly graduated critical care fellows. They asked some questions on boards about the ventilator, but it's really like very basic stuff like, asthma and bronchospasm and high peak area pressure and the blood pressure is low. Like, what do you do? Disconnect the ventilator because of auto peep. And so that's like very surface level kind of stuff. But really dissecting the waveform is something that we're not taught. And I wish we were taught it, obviously. So I'm going to teach it to you. So the goals, we're going to identify why dysynchrony is important, identify some patterns, and then apply simple bedside fixes. That's probably going to be more like tomorrow, but we'll, in the slides, and I sent these out so you guys have them. I didn't really make a lot of changes, but if I do, I'll obviously update them, and then you'll have like the most updated stuff. In there, I sort of put how to fix, and that really depends on a lot of different things. For example, if you have like a flow dysynchrony and the patient wants more volume, if you can't give more volume because you're tied to like some low total volume strategy, then obviously that's not going to be the fix, right? Like I can't sort of just give the patient more volume. Can you play around with the inspiratory time, which in volume control will, make the flow different? One thing that I'll finally be able to hash out here is that even though, so PRVC, we know it's sort of like the bane of my existence, but a lot of times when I put up waveforms about PRVC, everyone just says increase the flow. And through the PRVC sucks webinar and other things, we've figured out that we probably can't do that. We can't just increase the flow because the flow is an unfixed variable. So the patient can take as much flow as he or she wants. The real point is that can we be doing something differently or changing the ventilator mode, because that vent mode is not really good for the patient in that scenario, i.e. flow, like sort of flow starvation, support starvation, meaning the patient wants more support from the ventilator. With PRVC, as they do more and more work, they're going to get less and less support. So maybe it's not a good mode for them, right? We need to change it, but we need to start identifying that. What I want you guys to take from this is that you should be expecting a certain waveform on the vent if the patient is passive and you're getting flow and volume just by the mechanics. And if it's different than that, then something else is happening. Either the mechanics are off or something that the patient's doing. So this is going to be really pedantic for a second, but dysynchrony versus asynchrony. In the literature, it's asynchrony. I was initially taught dysynchrony. Some people say dysynchrony. I guess it's technically asynchrony. If I want to be really anal about it, which I will be for a second, when you talk about asynchrony, it's sort of like absence of as the prefix, whereas dysynchrony is like disordered. So asynchrony sort of implies that there's a timing issue. Like it's just the vent is like mistimed. So if it's like a cycling asynchrony, then if you just fix the timing, then the asynchrony will go away. And that's certainly possible. I guess for me, not everything is like a timing issue. Some of it's like a support issue. So I think what Melody and I have come to the understanding is that I'll say for me at least, I think she would agree, but I don't want to put words in her mouth, is that I like dyssynchrony better, even though we say asynchrony in the literature, because it sort of encapsulates that not only can the waveforms sort of demonstrate, mistiming, but can also demonstrate, under over support, whereas like asynchrony doesn't really capture that stuff. But that's just really sort of, pedantic. Okay, so at its root, when we have some ventilator waveform, when we set the ventilator, whether it's RT or, the physicians or we're gassed up, Jonathan. That's right, my friend. When we set the ventilator, and if it's either volume control, pressure control, PRVC, whatever you're setting, you should expect to see some waveform that looks normal, like sort of normal in air quotes. And I'll show you sort of what we're expecting to be normal, and that's based on the equation of motion. I've talked about this before. For my nursing bedside friends and, even like maybe medics or HEMS people, this is nice to understand. It's not absolutely necessary for my critical care peeps, fellows, attendings. This is probably more necessary to understand like the sort of the ins and outs of it. But what you see is based on the equation of motion, meaning like the pressure, flow, and volume is based on the equation. So if you have some delta pressure and you get some delta volume, if you start playing around with certain variables, let's say the compliance, the waveform should change in response to that. So what I mean is when we intubate and paralyze someone and you dial in PRVC or pressure control or volume control, you get, a waveform that's generated by sort of the patient's mechanics at that point in time because they're paralyzed. Now, when you add the patient into it after the paralysis wears off, now the patient starts to interact with the ventilator. And then depending on the mode, whether it's sort of pressure-based or volume-based, when the patient interacts with the ventilator and is either sort of mistimed or takes more flow and volume, the waveform is going to change. So, the crux of this is to understand sort of what normal looks like, what we should be looking for. And that's difficult in some way, for every level of provider, unless you do this sort of on the reg and practice it. And I didn't link this study, and it doesn't, it's not like sort of groundbreaking, but the critical care research group that is in the DMV area, where I am, between like the NIH and like University of Maryland and Hopkins and Georgetown and Washington Hospital Center where I trained, they published a study where, fellows who went through this training, in the beginning had the highest level of competency, obviously. And then over time, it decays. So they start out at like 90% competent with waveforms and identifying dyssynchrony and all that kind of stuff. And then it decays over time. Unfortunately, unless you practice it, it is going to decay. So a lot of this is going to be on you guys to, what the knowledge that we sort of get here, you're going to have to apply it at the bedside. I'll take a second to say that, part of why I do this is to sort of be accessible. So if you have something sort of like going on with a patient and, the vent's alarming and you did this dyssynchrony thing with this like vent guy on Instagram and that doesn't sound overly sort of, like official, but if you snap a picture of the waveform, send it to me, and then we can sort of talk about it. And then this is how you sort of gain expertise over time, is like to practice this stuff. Okay. But you have to bring it to someone that sort of knows what they're talking about, because I don't want you to be led astray, obviously. So, all right. So why is dyssynchrony important? Dyssynchrony is important. The literature is sort of, one meta-analysis shows that there's sort of this mortality benefit. Another meta-analysis does not show the same mortality benefit. I recently did a podcast with the critical care scenarios guys, Brandon and Brian, who I love. They're great dudes. They do a great podcast, very well done. And Brandon asked me the question, like the very basic question, like, because we talked about PRVC and he sort of loves PRVC, and all my sort of PRVC bashing recently has got him feeling a certain way. So he invited me on the pod and said, we were sort of going back and forth. So he brought up the point of like, if the ventilator is supporting the patient less, like, why is that bad? Right. Which, I think is like, it's a basic question. Maybe we overlook it at times, and maybe I shouldn't overlook it, but there's a certain amount of work that needs to be done by someone in order to move gas from the ventilator to the patient's lungs. Right. And just at its very nature, we call that the work of breathing. So we need a certain amount of pressure delta to sort of drive flow and volume into the patient's lungs to give them a total volume. So that begs the question, who do we want doing the work of breathing? Do we want the patient doing the work of breathing, or do we want the ventilator doing the work of breathing? So if we want the ventilator to be doing the work of breathing, if we're having dysynchrony, the patient's doing more work either through contracting their diaphragm and not getting a breath, so like ineffective triggering, contracting their diaphragm very vigorously in pressure or PRVC and getting a big volume for whatever reason. Maybe they have metabolic acidosis, maybe they are in pain, maybe they have some other drive to breathe that's very profound. But there's a certain amount of work or breathing that needs to be done. And who do we want doing it? Do we want the ventilator doing it, or do we want the patient doing it? We want the patient to be doing some work. When you have a lot of dysynchrony and sort of these asynchrony index and mistiming, all these things impact the diaphragm and can cause diaphragmatic dysfunction and injury, which can then sort of prolong your ventilator length of stay. And maybe that doesn't have like a direct mortality correlate, but if you're on the ventilator for 2 extra days, that's 2 extra days in the ICU at least. That's 2 extra days of being exposed to the ventilator, exposed to sedation, exposed to immobility, exposed to possible VAP, exposed to possible DVT, exposed to possible other iatrogenic injury. Doesn't come without risk. I mean, at any point in time, the patient can get a pneumothorax, right? Even just sort of normally. So I think we sort of underestimate, how important like dysynchrony is. When it comes down to it, we want the patient to be comfortable, certainly. And if they have a lot of dysynchrony, it's certainly uncomfortable. So when we look, we find that a lot of patients have dysynchrony. So the AI is the asynchrony index, and they ran it through AI, so artificial intelligence, to see how much asynchrony there was. And, there's a considerable amount. And they consider over 10% to be sort of like a number where they put a lot of credence into. So like more than 10% asynchrony reflects some sort of morbidity and mortality. The most common ones were ineffective triggering and double triggering. So we talked about this, high patient ventilator asynchrony, so PVA. You can have a longer ICU stay, and that sort of has all these downstream effects. So immobility, delirium, etc. Lest we forget that, ineffective triggering exposes you to, sort of over or under support on the vent, which then leads to diaphragmatic dysfunction, which then begets, is this patient failing SBTs 3 or 4 days later because there's something sort of wrong mechanically with their lungs, or they just sort of so deconditioned because they've been working so hard for 4 days because they've been so desynchronous with the ventilator, but no one's recognized it. So you're just impounding them with sedation, more propofol, more ketamine, more Precedex, more fentanyl, more Versed. Now they're just in this haze. And then you want to extubate them, 3, 4 days later. And not only do you have to contend with all the sedation that's built up, but you have to contend with, the fact that they're weaker because they've been fighting so hard for days against these dysynchronies that have gone unrecognized. So I don't know if we're going to have a great, I think I could say with certainty, we're not going to have a great RCT that says, if we need this much dysynchrony is bad, but less than that number is okay. But what we should aim for is sort of like, setting the patient up for success and not just, sedating them into submission to our settings. I think that's like an okay bar. Controversial, but it really shouldn't be. So this was a nice paper from Burchard, and Thomas Piriano was on it as well. So this is a nice figure, right? The patient has to interact with the ventilator. You add in the diaphragm and the lungs. If these things are off, then we start to introduce morbidity. And as we introduce morbidity, we sort of beget mortality at some point, whether that's, and so just as an aside, ventilator associated pneumonia sort of starts at day 2, then it has this kind of like additive risk profile that goes up to maybe like day 7 to 10. Once you get to day 7 to 10, you sort of like get out of this additive risk file, then you're just like at risk for it. But every day it sort of goes up by a certain percentage point. I don't know, 2%, some number. The absolute numbers are relevant. The point is that, if you're on the ventilator for 2, 3 extra days, that's significant enough for the exposure to ventilator-associated pneumonia. So if you have a lot of dysynchrony that is unaccounted for and it's adding a couple days, 2, 3 days to the ventilator, and I think you guys have seen this, right? Like, I mean, I've seen it recently where patients really desynchronous, they get sedated, and then it takes like an extra day to sort of like way through the sedation. So, you stop the probe, you start Dex, come down the fentanyl, they're fighting, they get some overnight. The night person like goes up on it, or they add in Haldol or something, right? So you sort of fight this day of kind of like desedating to some degree, even though we shouldn't be doing that. We know that increases mortality and ventilator length of stay, ICU length of stay, et cetera. But like that's what happens. So we add in another day, 2 days, but that has real consequence. So can we set the ventilator up better so the patient isn't on it for any longer than they need to be? That should be our goal. This is a study from Eduardo. I never know. He's got like a hyphenated last name, so I never know what to say. So I just call him Eduardo. Super nice guy, Cleveland Clinic, with Chapburn, wrote like the seminal paper on classifying ventilator modes, sort of like by the taxonomy, which I haven't memorized or committed to memory, but if you're learning it, you have some time, you definitely should. And then another doc, so Miguel Ibarra Estrada, he's in Mexico. He does a lot of great work, super smart, not on the gram, but on other socials. He's like still on Twitter, but super smart guy. They do a lot of research. Anyway, so they surveyed RTs, nurses, physicians from like around the world, not just America. So, our South American friends, who by the way are much better at mechanical ventilation than we are, sort of as a whole. So like Brazil, Argentina, like all these guys are much better than like the Americans at mechanical ventilation just in general. I don't know why. They just sort of pay attention to it more. But so they did a survey, I think it was like 10,000 respondents, so a lot of people, right? So if you notice, and honestly, I kind of saw the same patterns in that waveform quiz that I sent out like 2 or 3 days ago. So I got about 57 respondents. So, not like a huge sample size. And obviously this is going to be like the nerdiest of nerds. So, you would expect sort of like a very nuanced perspective from that group of people. But much like I saw in my little kind of quiz, the flow starvation waveform got about 30% correct. And in this study, the flow starvation waveform got about 30% correct. So people can recognize condensation. We could recognize pressure overshoot. We can recognize bronchospasm. We can recognize emphysema. I'm not even really sure what that means. Late cycles, like leaks. But as we get into these things like failed trigger, so like ineffective triggering maybe, early cycle, so early cycling is like premature cycle, meaning the vent is shutting off before the patient's ready to shut off. The most extreme form of premature or early cycle is like a double trigger, because the patient sort of pulls through the whole way and lets the ventilator know he or she wants another breath, so it triggers again. So it's a double trigger. But sort of that PRVC waveform I put up a few weeks ago that got a lot of sort of, or I think it was I don't know, the one post, the PRVC sucks, that got everyone sort of like in their feelings. Everyone's like, a lot of respondents in the comments was, they said, we need to recognize flow starvation better, or whatever, right? So that was something that we're not good at recognizing. So in this study, it was one of the least recognized dyssynchronies. So 30% ish, highest recognized by RTs at about like 40-45%. And in my little quiz, that one was one of the least recognized dyssynchronies. Now flow starvation or support starvation, we'll talk about that in pressure control. That really ties to like morbidity piece, because if you're starved of flow or starved of support or starved of volume, that essentially feels like you can't breathe, right? Like you're not breathing, you can't breathe, not getting enough air. Tobin had that study from before that ICU boy brought up, where he questioned if PSILI, which is like patient self-induced lung injury, which is this whole subset of things that the vet nerds talk about. But essentially, when you talk to a patient afterwards and they have some recollection of their time on the ventilator, they're like, I felt like I couldn't like get enough air, right? So, talk about being tortured, right? And then they start to do stuff, they're agitated, then we start hitting them with drug, and then, we sort of start going down the rabbit hole. So, this stuff, while maybe not shown in some large, RCT meta-analysis to really, mortality benefit, et cetera, like when you get down to the patient bedside level, this stuff's important, right? So, it's obviously important to look at literature and look at studies that support what we do, but we can't lose sight of the fact that, we shouldn't need a study to prove that we shouldn't torture people with the device. Like, I think that's a pretty low bar to set, right? And then I added this morning just to remind us that, so remember, very important, small study, single center, I think it was like 100 patients or something. And I think I think we see this too, right? So just because a patient's sedated, right, their RAS is -4, that doesn't mean anything about their drive to breathe. Like they can have a tremendous drive to breathe still, but be, you know, be sedated, right? Their RAS can be -4 and their drive can be very high. And we saw this a lot. And, I have a smattering of people. I think some of our friends were, did our COVID sentence, right? And we saw this all the time during coronavirus, right? The RAS is -5, but they're still breathing, double triggering, etc. Most of that was probably reverse trigger, unfortunately, so our bad. But it just goes to show you that you can be very, very sedated, but not, still have a drive to breathe. And this study supported that because they, got the sort of PO1 numbers. So the occlusion pressure is, I did a reel on this before. So essentially, it's some number that it correlates very well with drive to breathe. So it has nothing to do with like work of breathing. It's just like drive to breathe. So if you have a high drive to breathe, that could be a lot of things. It could be pain, agitation, acidosis, sort of the things we think about like high drive to breathe, just like neurologically. So the patients the patients that had the highest drives to breathe were the patients that had the deepest RAS scores in this study. So if your RAS was like -4, -5, you still had a pretty high drive to breathe. That's because normally when we do this, right, these patients are very sick. They have acidosis, they have ARDS, they're very air hungry. And we say, okay, maybe we say, and maybe not, but maybe we say, listen, this patient can't be involved in breathing right now for whatever reason. They have ARDS, they're acidotic, we need to do other things. So then we start to sedate them more and more, but that doesn't really knock out their drive to breathe. Sure, if you have a patient that is not critically ill and you give them a slug of fentanyl, then it might decrease their drive to breathe. But as you get more and more critically ill, your drive to breathe is more and more intact. When you think about it from like an evolutionary standpoint, that is evolutionarily beneficial. If you're very sick, so back to sort of like the basics, which is, when you're very sick, you have like this, you need to sort of like move a lot of gas with gas exchange for either oxygenation or to get rid of acid, right? You're generating a lot of lactic from sepsis or whatever it is. You have to deliver more O2 to the tissue. So you need to breathe harder and faster, just like exercise. So when you think about it from that perspective, it makes sense that, if you are very critically ill and you need to move a lot of gas to get oxygen and blow off CO2 because you're generating a lot of acid, you would want a high drive to breathe. Obviously, your body doesn't know, like, hey, you're intubated. We're doing this for you. Just chill out, bro. Like, we can't say that. So we just start slugging them with drug. But your drive to breathe is a highly guarded reflex, right? So it's good that we have this reflex in place. Obviously, at times it doesn't help, and we have to sort of negotiate what we're doing with the ventilator and what the patient's doing. All right, so my general approach to dysynchrony is, what's normal? What's normal for that mode? So the three general modes we'll talk about is like adaptive, so PRVC for other people that might be VC plus, it might be autoflow, it might be APV and whatever other Hamilton jargon there is. But like this adaptive mode, volume control strictly, so we're controlling the volume and the flow, or pressure control. Pressure control and pressure support are sort of the same thing in my mind. Remember, if the patient's breathing spontaneously, so they're initiating their breaths and you're on pressure control or pressure support, the only thing that's different is the cycle mechanism, meaning how does the ventilator know to go from inspiration to expiration? In pressure control, it's a time, 1 second, 0.7 seconds. In pressure support, it's the flow decay, or some people call it the E sensitivity, and there's other words for it, but cycle decay, flow decay. So if you have a peak flow of some number, so 100, let's say, if you set the decay to 25% of that, when the flow decays to 25, the vent will cycle off. And this might be better sort of drawn. So if we say, let's say pressure control, right? So we're setting the cycle to some number. So at 1 second, it'll cycle off. So we set that. So this inspiratory time is 1 second. If we have pressure support, and we set that to 25% of the peak. So if the peak was 100, when the flow gets to 25, let's say 25 is right here, the vent cycles off into expiration. Do we see the difference? So the difference is here, 1 second. So that's some absolute number. Here, the difference is when the flow decays to that number. And that, depending on the mechanics, that could be longer or shorter. Meaning if you have high compliance, so this high compliance situation, let's say like emphysema, So for every breath, you're going to get more and more flow. It's going to take longer and longer for that person to get to 25% of their peak. So for them, 25% of their peak night might not be till like here, right? And then it'll cycle off. But because they were in inspiration longer, they got more volume. So the area under the flow curve is all volume. Getting back to this, if you have someone breathing sort of triggering breaths on pressure control, then the difference between pressure control and pressure support is just the cycling mechanism. I think that's an under recognized sort of thing, honestly, but that's how I think about it. So for this sort of class, for the camp, think about pressure control and pressure support as sort of the same thing. All right, so normal waveform. So you can so screenshot this, take this to the bank, have it on your phone maybe or something. Jonathan might have it on his new lanyard when he gets his new job. The point is, when you have a patient, right, and the vent's like going crazy and they're on, let's say, PRVC. If it doesn't look like this or pretty close to it, then the patient isn't passive and we're not delivering volume based on the mechanics. Oftentimes, what's going to happen with PRVC, because we know it sucks and it basically sucks. Anyway, what's going to happen here is that the flow curve is going to kick out, right? And I've done probably too many like reels and all kinds of stuff on this. So, what we call this in pressure control, so the flow, what we call this in pressure control and in PRVC, so like these pressure-based modes, the flow should decay based on its just sort of the resistance and the compliance of the lung itself. So it should have this sort of natural decay feeling to it. So it should sort of peak, and this peak flow, if you're just talking about no patient effort, so the patient's either passive or paralyzed, the peak flow here, the peak inspiratory flow should just be based on the delta pressure. Same thing with PRVC, right? The peak flow should just be based on the delta pressure. As you fill the lung up, which is represented by this reddish line, so this is the alveolar pressure, as the alveolar pressure rises, that delta pressure goes down. So as the delta pressure goes down, you're going to get less and less flow. So it's going to decay down to some number. If at end inspiration, those pressures are equal, then the flow is going to be zero. And then here, at this point in time, the peak airway pressure is going to equal the alveolar pressure. So P airway equals P al. So if we've delivered a volume just based on that delta pressure, does anyone want to take a stab at what we might call that? And this is where some people get confused, and maybe we'll be able to, especially for my Hamilton peeps, I want to make this point. We won't belabor this, obviously. If we deliver a volume based on a delta pressure and the flow goes to zero, we can call that the driving pressure. So while we think of driving pressure as plateau minus PEEP, so like sort of the driving pressure, here old school docs will talk about the inspiratory pressure, the delta pressure, the pressure applied, whatever you call it. They might call that the driving pressure. The reason they call that the driving pressure is because that delta that we set delivered some volume based on the mechanics. The point is that if you still have flow here and the flow doesn't go to zero, then you don't know what the plateau pressure is technically, because the peak airway pressure does not equal the plateau pressure. So if the flow doesn't go to zero, you can't presume that the peak airway pressure is the plateau pressure. So if you're, Melody tells me, especially on Hamilton, it's sort of, some people think the driving pressure is whatever you sort of apply. The key is that the flow needs to go to zero, because then you know that the peak equals the plateau or the P-alv or the at end inspiration, only if the flow goes to zero. If the flow doesn't go to zero, we don't know what the plateau pressure is, especially if the patient's taking a breath. So if the patient's breathing spontaneously on top of that and taking sort of a bigger breath than just their mechanics would allow, on the next breath, if we did an inspiratory hold and measured a plateau pressure, that plateau pressure might be higher than we expect, because we're not delivering volume just based on the mechanics. We're delivering volume based on the mechanics, but also based on the patient's interaction with the ventilator. Because remember, in pressure control and PRVC, in these adaptive modes, the flow is unfixed. The flow can change. So they can take more air from the circuit than just their delta pressure would allow. Okay? So in pressure control, really in pressure support also, but also PRVC, if the patient's not interacting with the ventilator, then it should look like this to some degree. If it doesn't look like this, then something else is happening. And that's, that's a good starting point. Where you would look is in the flow and the volume piece. And I talked about this before. So, these are the things that will change. So this is kind of nuanced, but I think it's good to point out. So remember, in expiration, and maybe I shouldn't presume. So if I drew sort of a line across all of them, I'll try to make it as straight as possible. This in flow, at least, this part is inspiration, this part is expiration. So it's kind of the flipped mirrored of like a spirometry. If we have any of our pulmonary friends here, a spirometry is sort of like expiration is like above is the superior piece and inspiration is the bottom piece, and then it's sort of mirrored. But if you took a picture of a flow curve and sort of like flipped it and mirrored it, it'd be the same thing as a spirometry tracing. Okay. The point that I'm trying to make here is that all the time in expiration, so even in the flow curve, in the volume curve, so this is, inspiration ends here and then we go into expiration here. And then for the flow, expiration is always sort of this unfixed variable. So if the patient's like blowing out, you're going to see that in the expiratory flow and volume. And I have an example of that. So the places where you're going to see pathology is always in expiration. For the pressure curve, remember, the vent sort of sets the expiratory pressure. So it sets the expiratory pressure, also known as the PEEP. The vent can't see anything besides what it thinks the PEEP is unless we ask the vent to see it. Meaning the vent can't see auto PEEP unless we ask it to see auto PEEP through an expiratory hold maneuver. So we press the expiratory hold button on, let's say, the servo, the Puritan Bennett, or their Hamilton. That's not a T1 because the T1 can't do it. And then when we press the expiratory hold button, the ventilator actually will transduce the pressure. So if I'm here in the PRVC adaptive one and I press the expiratory hold button, and let's say the PEEP is supposed to be 5, and then you press the expiratory hold button, the ventilator sort of senses the pressure, and the pressure starts to rise to some number, and let's say it's 10. That means that there's 10 extra centimeters of water that was unaccounted for by the vent in the airway. So what that means is that there's 5 centimeters of water of extra pressure, which we would call auto PEEP. So total PEEP is 10. We're setting 5, or we think we're setting 5. So the set PEEP is 5, and then the auto PEEP becomes 5. Okay. So in expiration in the flow and volume, we can always see pathology. Depending on your vent mode, it's going to depend on if you're going to look at the flow and sort of the volume waveforms to look for pathology, or the pressure waveform to look for pathology in your volume control modes. So this would be something maybe to screenshot for sure, because if you're not sure what it should look like and it's sort of like out of control, and we've seen some crazy waveforms, right, in the past like 18 months, going back to what it should look like is a good starting point, and it's what I do still. So what I want to I'll do really maybe with the next couple minutes, and then we'll take our first break because you guys are probably fried. This is pressure control, and even though I think pressure control is one of the harder modes to really master, I think it's the easiest one to get an understanding and then move forward from. So in pressure control, and this is a little advanced, so if it confuses you, no worries. We can always talk about it more and sort of like circle back to it, etc. But if you think about the equation of motion, so the P airway equals, here we go. All right, so the airway pressure equals the flow times the resistance plus the volume over the compliance plus the PEEP. So it's really the PEEP total. This term, volume over compliance plus PEEP total, that's also known as your P-alv, or your plateau pressure. Okay? I know this is confusing. Stay with me for a second. So let's break this down into 3 points. We're going to say here, here, and here. So the 3 red dots. In the beginning of the breath, we haven't delivered any volume. So I'm going to try to draw a blue line through that's straight, and it's really crooked, but it's the best I can do. So in the beginning, no flow, no volume has been delivered yet, right? So the airway pressure, when the ventilator first kicks on, is made up of the flow, the resistance, and the PEEP, because this term goes away because there's no volume delivered. So 0 divided by C equals 0. As you deliver flow, so we get to the second red dot, the alveolar pressure, or this term, sort of comes back because now we're delivering flow and volume over time. So we have a total volume that starts to get delivered. So now the alveolar pressure will rise. So it rises to some number sort of in the middle of the breath, right? So now that volume over compliance number comes back. That volume over compliance term comes back, But as we deliver volume, the alveolar pressure rises and the delta pressure, so the difference between the airway pressure and the alveolar pressure, gets smaller and smaller. So your flow goes down and down. And that happens when you take a spontaneous breath also. So if everyone here sort of starts to take a breath in, you'll notice that, the most flow is sort of in the beginning of the breath because that's when your delta pressure is the biggest. As you get closer to the end, it sort of goes less and less. And we do this all the time. We don't think about it. Now that I'm pointing it out, it might sort of change. But if you're sort of sitting there quietly, just breathing, as you get closer and closer to end expiration, that flow goes down. Now, it goes down. If we set the vent to the numbers and we got the flow to go to zero, then at end inspiration, if the flow is zero, then the flow times resistance number goes away. So now the airway pressure is equal to the alveolar pressure, which is the volume that we just delivered over the compliance plus the PEEP. So where we started and then sort of where we ended. So the airway pressure equals the alveolar pressure. Now, there's this other term, PMUS. So PMUS is for muscles, sort of muscles of inspiration. If you, and even now, right, if we took like this aggressive breath in, you'd notice that the flow would go up and you sort of get more air, right? You'd get more tidal volume because we're sort of forcefully contracting our diaphragm. If our patients do that, then they're also, and this is pressure control, remember, so the flow and the volume can change. So what's going to happen if the patient, drops their diaphragm? So if we had a PEEP of 5 and then we set, a delta of 10, then the peak would be 15, right? Let's say the patient drops their diaphragm and they generate, 5 centimeters of water of pressure. Now it's coming from the bottom. So by convention, we make it negative, and then someone will point out the algebra to me and say it's negative. So it's a plus minus, it's positive minus a negative, whatever. But just think, I'm pushing from the top and you're pulling from the bottom. So you're adding 5 centimeters of water of extra sort of delta pressure that wasn't there before. So what should we expect, here? What we should expect is that maybe the flow would be higher. And then, on the next breath, what would happen to the flow? The flow would be higher, and then they might get more flow for their breath cycle. Because remember, it's not just based on the mechanics anymore, and it's not decaying to zero. The patient's doing work, they're influencing the circuit, and they're getting more flow and volume. So now the flow curve kicks out to some shape, right? And the shape is all different. And this is just me sort of, maybe I am like sort of really embellishing a little just to show you the difference. But the flow curve is going to kick out. And, instead of getting this tidal volume that they got before, so the area under this curve, the initial flow curve, they're going to get a bigger tidal volume. Maybe a tidal volume that you don't want them to get. So they would initially get, the red that's under this flow curve. But now they're going to get, the red that's under this flow curve, which is much bigger. And this is problematic, especially if the patient's supposed to be on low tidal volume ventilation, let's say, right? And if they're on PRVC, so this is pressure control. So for pressure control, they just get a bigger breath and then that'll be that. Remember, on PRVC, what will happen on this breath, like the vent will say, we pressurize to the same number, but I got a bigger volume. So then what's the vent going to do on the next breath? It's going to pressurize to a smaller number because the vent's trying to give only enough pressure for the volume that we set. So this is how we set the patient up to be sort of tortured because they want a bigger breath. There's a certain amount of work that needs to be done to get that breath. If we have them on PRVC or in an adaptive mode, as they do more work to get a bigger breath, the vent's going to support them less and less because the ventilator thinks to itself, wow, I set the delta pressure at 10 and, we only want a volume of 500, but the patient got a volume of 700, I better dial that back to 7 or something, right? And then it goes down. But the patient is on the other end of it, just, reacting to what the vent's doing, and they want, they're going to want what they want for their pathology. So if it's ARDS, metabolic acidosis, whatever it is, they're going to want what they want for their pathophysiology. The first branch point is, can we allow them to do that or not? If you say they have ARDS, they can't get a 700 cc total volume, that's fine, right? That's completely fine and reasonable. But that's where you have to start to take over. Whether that's more sedation, which we just said doesn't work great. I mean, it doesn't. It can do stuff, right? But at that point, if you're getting that into the weeds, like, do you have to paralyze the patient, right? Like, do we need to really take over and do paralysis? That's where, the question, and that's a clinical call on your point. So my point here is that while you don't need to understand every waveform, like draw it out and all that kind of stuff, it should look like one of these. And if it doesn't look like this, and remember with PRVC, it's still going to have this sort of a square-ish shaping look. And although it can be deformed, and we have examples of that, obviously. But in PRVC, if it's not looking like this, then something is wrong. And generally, it's this like flow issue. So generally, it's a support issue. We call it, some people, we still call it flow starvation in pressure control modes. I'm also guilty of this. It's technically not accurate, right? Because the patient can get as much flow as he or she wants because it's unfixed. The question is, are they getting enough support from the vent to sort of get that flow and volume? Is the ventilator doing most of the work or is the patient doing the most of the work? That's where the difference is. All right. So I think that's a good place to take a little break. What do you guys think? Maybe it's like 10:59. Want to give it like I don't know, 8 minutes, somewhere like 8 to 10 minutes. Get up, stretch your legs, go pee, get some coffee, smoke a Winston or something. All right, awesome.
Hey Nick, when we
Yes, sir.
come back, can you go back to that real quick? And
Yeah.
just when you're talking about like CMV or PRVC,
Yeah.
we can do it after the break. Like, just go back over what else are you going to see that, because I get it, right? Like
Mm,
now it's going to give it less pressure because it doesn't think it needs it because of the volume it got. It's always adapting, right? Can you
yeah.
go back after the break and just talk about other things you're going to see, whether it's XL tidal volume or other things that may also clue you in outside of waveforms? And if it isn't just trying to wrap my head around that part a little bit more. So
Yeah, yeah, yeah. No, that's fine. We can go back and we can do that for sure.
if
I'm
it
just
fits
trying to
in
think if
better
I have
somewhere else,
other.
that's fine as
No, no.
well. Just
I have some PRVC dyssynchronies in like baked into the examples. I don't remember which ones. Let me see
because
here.
I'm using a T1 in our flight stuff.
Yeah,
So we're
yeah.
going to have
Right.
pressure or we're going to have CMV or PRVC. So
Right.
just trying to like make sure I'm really
No, I
solid.
know. And yeah, yeah. Well, and lucky for you, Melody always sends. Let me see here. I'll just look at it now. Lucky for you, Melody always sends me T1 like
Okay.
waveforms that she gets. I don't have any here.
Okay. That's all right. If
No,
just
no, it's fine. I'm just trying to think. No, no, that's fine. We can either do that or barrel through and then I'll point out because what it comes down to is that it's not gonna be any different than like pressure control in the other stuff because it's a pressure controlled mode. You know what I mean? So what you see on pressure control is what you're going to see on PRVC. The difference is that, and which makes PRVC worse, and like, your APV or whatever it is that as you get more and more work from the patient, the vent's going to give less and less pressure.
right.
You know what I mean?
Yep.
So a lot of it's going to be similar to, whereas in pressure control, it's going to give you a certain amount of pressure the whole time. So, whatever it's delta 10, delta
Your volume
15.
may change, but your pressure is going to be consistent.
Yes, right. Now, not that I'm saying like pressure control is not like a panacea. It doesn't like solve all your problems. But like I said earlier, if there's a certain work or breathing and you're like, you have to make a decision and say, who do I want to do the work? Do I want the patient to do the work? Do I want the ventilator to do the work? So what I do usually, what I see a lot of times at least, is that if I switch them, if they're on PRVC and they're sort of being tortured, and I switch them to pressure control, I either have to be able to accept higher total volumes, either initially or in general. But a lot of times, and you probably see this too, is like we'll dial in some volume and the patient will do whatever. And then they might get sort of tachypnic and get auto peep and do all this stuff. If you give them a bigger breath, definitely in like COPD, and this happens all the time in COPD, it's like the perfect storm because our COPD friends, they're used to taking big breaths, but like not often, right? Because of their compliance issues. So depending on your program, like my old hospital, let's say, like they would lock everyone into 6 cc's out of the gate, right? So, you have a COPD patient that's used to taking a volume of like 600, then you lock them into like 470 or something.
Right.
Their minute ventilation, let's say it was a 600 total volume because I can't do math. And let's say they have a
Six or
600.
7 minute ventilation.
Yeah, they have some, right. They have let's do 6 and 3 because it'll be easy, the math.
Okay.
So you have a 600. So, Mr. COPD guy, sort of short guy, not that big, but like takes a big breath, 600 ml as his total volume, but he only breathes 10 times a minute, right? So that's an MV of 6.
Right.
Now we intubate him, and our protocol, because you guys love your protocols, says that we got to do 6 cc's per kg. And let's say 6 cc's per kg is like 350 or something, right? So I basically halved his tidal volume. So what he's going to do usually is, that 6 cc MV didn't really change. But if you're only going to really allow him to get a 350 tidal volume, and let's say, he pulls a little more, let's say he pulls like 400. So now PRVC or your adaptive mode is going to say, okay, he got 400, they want 350, so I'm going to down regulate the pressure. So what he does in response to that is like breathe faster because it
Yep.
needs to satisfy this 6 liter minute ventilation. So, you could do a 6 liter minute ventilation at 600 cc's total volume at 10 times, 10 breaths a minute. You could do a 300 cc total volume at 20 breaths a minute. The difference between those two things is your respiratory rate. And we know, we've talked about this ad nauseum, is that auto PEEP is a rate related issue, right? So as
Right.
he breathes faster and faster to get his minute ventilation, he's going to auto PEEP more and more. And then
This
you
is
start
where
to get
using the rate to get his minute ventilation is not helpful, where you needed the volume to get the minute ventilation.
kg is really hurtful.
Okay.
Because, and I don't know, you guys, I don't know if you like probably transport a lot of COPD people. You probably do to some degree. But remember, if you have a guy with emphysema, let's say, and they get intubated for like COPD exas, like, so ARDS is a little bit different because with ARDS, you have like even more heterogeneity in the lung itself. Emphysema is a heterogeneous process already, meaning some alveoli are much worse than others, right? So the time constant is going to be different. So maybe, one section of alveoli is really diseased where another section's not. But when you throw in ARDS, it just gets much more difficult. My point is that if you have sort of a pure emphysematous person and they're on the ventilator, the plateau pressure is never going to be 30, right? Like it's always going to be low because their compliance is so high. So my problem in this situation is like when we give them lower tidal volumes, let's say 6 or 7 cc's per kg, that's a really tiny volume for a very compliant lung. So your peak area pressure is often going to be like in the teens. So what I'm trying to say is that to get back to your point with the number tidal volume is I'll give them a higher tidal volume, and I don't generally care if it's like 8, 9, even 10 cc's per kg because even if I did a plateau pressure maneuver,
We're still going to have a low because
it's still going to be low. Exactly. It's still going to be low. But the difference with my way or my approach or whatever with the higher volume is that they're not going to be tachypnic and they're not going to get auto PEEP.
Yeah, no, that makes perfect sense.
You know what I mean?
Yeah.
But you're sometimes, depending on where you are and how you practice and all that kind of stuff, you might be sort of forced to do 6 or 7, right? Like your protocol might be like 6 or 7 cc's per kg or something like that. So I can't help you there, unfortunately, right?
No,
But
no, no.
you can make,
We've got a much more lenient side to that, but
yeah,
that
well, that's good.
philosophy makes more
But
sense.
you might be able to sort of argue with your superior, like, hey, even though we need like the 7 cc tunnel volume, the patient got COPD, like I think we could be more lenient with it, like type stuff. You know what I mean?
Yeah.